Good afternoon, respected faculty members, my dear colleagues. First of all, thanks a lot. People who are sitting here after a heavy lunch session. We will be able to talk about this advanced in plastics. I'm going to start out with the management of squeeze in plastics. When it comes to squeeze in plastic, we are reading about different conditions in which squeeze in plastic both of them correlate or interrelate each other. So we are referring to inflammatory conditions like thyroid disorders, inflammatory operative diseases, retinal dermatitis, Rosas-Hunt syndrome, third pulse, double pulses, myasthenia gravis, orbital flow fractures, to name a few. We will be discussing each and every condition, and we will just going through and running through the slides. Since we are short of time, I will just go into a brief overview about how school is managing such special conditions. So when we talk about plastic setups, what do we really mean? We mean doses, retractions, orbital space occupying lesions, all palpable visual variations, protocosis, which may be pulsatile or non-pulsatile, and anaphylaxis. This is a brief small chart just to make us understand how to make a decision in managing a school and process case combined together. So if a patient or process comes with a study specific opening, I'll try to differentiate the patient as a bilateral or unilateral school. If it is bilateral, I'll evaluate the elevator function. If the elevator function is normal, it is more likely to be in favor of myasthenia gravis. If it is likely to be a normal liver function, then I try to tell whether it is a sporadic case or a family case. If it is a sporadic case, more likely to be in favor of cardiopathy. If the case is having a positive strong family history, think about Fabry syndrome or CTE. And then we can consider inherited cases which might land up being diagnosed as elevated paralysis with cirrhosis, or maybe after following a large surgery of squint of conjugal muscle. So we start with the first case, the case of double elevated palsy, in which 24% patients do present with ptosis and 75% patients present with cirrhosis. The presentation is very typical. The patient is going to have total elevation deficit because of palsy or severe depression into the oblique. We evaluate the patient in the OPD by different kinds of techniques which we all are aware of. The most common method of managing this case is a NAS procedure, which was followed till date. NAS procedure includes a full tendon transfer of medialis and lateral muscle to the site of insertion of superior muscle. This might be superadded with a posterior fixation suture, that is a Foster style suture. We are trying now clinical practice something called as a minimally invasive NAS procedure, in which we create a supratemporal and supranasal incisions, which are conazal incisions. These incisions help us to drag the LR and the MR towards the insertion of superiorus, and these incisions are self-collapsible incisions and we do not have sutures also. Conditions of myasthenia gravis, almost 50% of myasthenia gravis patients do present with ptosis. The ptosis typically gets worse at the end of the day, and the patient is completely diplopia also. The most common used diagnostic procedures involves Copan, sign or ice pack test or phenylephrine test or an electrophoric test. Wherever the facility is available, we can think about doing EMG also. The first level management of squint along with the doses in such conditions is using medical management like anticoagulation medications like pyridostigmine or stigmine, steroids, immunosuppressants, plasmapheresis, IV hemoglobin, and chemical interview. Surgical treatment is managed only after 1 year of routine, and the most common way of managing this is the routine recess procedure as per whatever amount of squinting necessary remaining in. In case of ocular metastasis, also ptosis and squint is commonly noticed. Metastasis or wide-angle exotropia combined with hypertropia or hypertropia is commonly noticed. And we will do a detailed workup with such conditions. Management depends upon a proper thorough checkup and workup. So if it is secondary to vascular pathology like diabetes or hypertension, it needs to be addressed first. If it is secondary to internal pathologies, the main pathology needs to be addressed first, depending upon if it is a tumor, whether it is a hematoma or an aneurysm respectively. We have to wait and watch for the squint result for at least 6 months. And after 6 months, we can have a proper thorough plan of managing the squint. So you can see a small flowchart here mentioning how to manage the squint in the case of cerebral palsy. As far as the hereditary deviations are concerned, for hereditary, the first filter choice for us is supramaximal recession, depending on the LR activity. So we can go to as much as 40 millimeters of LR recession, or we might even pathanize it. And wherever the doctors are aware of this technique of something called as LR disensation and fixation of LR into the lateral manual tendon, that is also a very effective method in which we can totally accelerate the insertion of the apparatus to the LCD ligament. As far as the advanced strengthening procedures are concerned, we might think about a wide angle total amount of amortization as much as 10 to 14 million euros. And as far as vertical emissions are concerned, we can think about hypertropia, infra-placement of MR, or higher section can be considered. And for hypertropia, we can consider supra-placement of MR and might be covered in SR section. Some concept number, we should all vertical electric muscle sections don't work in these conditions, and you can think about something called a series bearing technique if you want to avoid anti-cellular ischemias. As far as thyroid is concerned, to the next topic, 30 to 50% of thyroid patients who have achondroplasia do complain with doses also. They complain with the retraction, they complain with process, optic neuropathy, and restrictive myopathy. We will do a thorough, detailed thyroid workup in these conditions, and the treatment plan is very simple. First, we have to address the process, which is the first preference, and the method of choice is steroids or immunosuppressants, or opioid decompression as per the case. And wait for 6 weeks, and then reassess the squid for diplopia in primary position and real conditions. And if it's significant, then you can think about doing an IR or MR section, or you can think about doing a botulinum toxin injections. If it is minimal, one can try about becoming spectacles also, or frenulum prisms also. Or idiopathic conditions like IOID or Down syndrome or vaginal matrices also the present with clinically pain, redness, and swelling and painful achondroplasia. They need a proper workup like CT scan or CNR profile, and such conditions are managed medically in terms of systemic steroids or immunosuppression therapy. Conditions like nerve fracture do also present us in our plastic practice, and patients do complain with lead-epidermosis, edema, loss of epidermis emphysemas, infraoperative nerve anesthesias, diplopia, and anaphylmos. No injuries also are noticed. The thorough workup in form of CT scans, analysis, head charting is very important. The proper documentation of muscle movements is must in such conditions. Treatment options depend upon the size of the wall defect and the tissue condition. So if the size is small and the diplopia is getting better day by day, you can think about observing and you can put the addition of oral steroids. But if the defect is larger and if the patient complains of diplopia which is constant and there is a muscle enlargement also noticed, one can think about doing the surgery as soon as possible. As you can see, this is the person has undergone the CT anaphylmos and muscle enlargement, has undergone surgery to reconstruct the floor with a different block, and patient will be really well. Another consideration we have used a proper mention is the liver retraction syndrome. In these patients have a significant liver retraction and significant split conditions also. The patient do present with different conditions like hector. They might present with significant low retractions, prominent options or downshoots, and might present with limited adduction. For hector, we think about the MR association in these conditions might be coupled with vertical rectus transpositions. If there is significant low retractions, we can think about doing an MR association, which might be coupled with LR associations. If anybody is having a prominent upshoots or downshoots, we might think about Y splitting of the LR, which might be combined with MR association. And anybody is having a limited abduction, we can think about doing a vertical rectus transposition, might be series bearing technique, or we can think about a partial reality of services. As you can see, this is a child having a shoot before the surgery had significant low retraction, underwent an MR association and a LR association combined with Y splitting. The patient is doing really well. We can see the retraction in the second photo after 2 weeks. The patient, you cannot see the retraction there. There are no visible upshoots and downshoots also in this condition. Similarly, this is CPO. Since there is a shortage of time, but I would just like to turn over the slides. CPO presents with process and slowly progressive bilateral ocular mobility, and the patient might be presenting with conditions like Lewis-Sirus syndrome. And such patients are managed depending upon the angular squid in the diplopia. If the larger the angular squid which is more than diplopia, we can think about giving a bilateral research procedure. If the diplopia is more than the squid, we can think about prisms and operation therapy. And if it is an intermittent thing, the choice depends upon the surgeon's preference. If it's a progressive phase, we might think about doing a botulinum toxin injections. I just run through this slide of the case of pulmonary fibrosis syndrome. The method of choice is using inferior restriction or MR restriction as per the clinical presentation of the patient. Results are very poor and patient needs to be counseled accordingly. Cardiac administration also present with pulse type hypothesis and doses, and a lot of patients which we have seen in finger practice with present with seasonal palsy. And the best way of managing seasonal palsy is to do something called a genesis procedure. As far as the managing CCA is concerned, the first line of action is doing the intermittent radiology, in which we think about doing a burn occlusion or mobilization, which might be coupled with oral steroids for 3 months, but the muscles will resolve, and then reassess the swing. And then after that, we can think about doing seasonal palsy contraction which might be combined with botulinum toxin injection. The Jensen procedure, as you can see here, the nerves split the muscle vertically, and then the muscle fibers are switched to a non-active Orient suture, so that we can transfer some sort of vector forces towards the paralyzed muscle. And this is really good in such conditions. Last topic which covers damage to muscle injuries, muscles in operative surgeries, especially anesthetic surgeries and silent surgeries, and which includes anterior operative approach with muscle recovering, and we have several options of managing them. We can either do a recovery of muscle directly by an anterior approach, or you can think about muscle transplantation surgery like conventional procedures, or Jensen's procedures of muscle modification, or you can as well think about doing inactivation of the adapters, like supramucosal recessions, denervations, or desensations. Other options like botulinum toxin injections are optional research conditions. As you can see here, there are techniques available and are followed like full tendon transfer techniques or Foster's modification. You can think about a Mogelson procedure. You can even actually think about the reversibility of the tendon transfer. Just to sum it up, this is a very big topic, a very confusing topic, and very difficult to put up in a small span of 12 minutes. But I will try to sum it up by saying that school is also very significantly in a lot of cases of oculoplasty. Oculoplasty cases and school cases do overlap each other, and most of them are congenital, neuro-ophthalmic, systemic, inflammatory, or related to space optical lesions, and hence the primary cause needs to be addressed before treating the spread. Decision making is the such cases, and the different outcomes are quite rewarding for the patients, since they get dual benefits for managing the oculoplasty condition also and the squint condition also. Squint measurements via the conventional mammograms might give us unpredictable results. The patients need to be counseled, and it's advisable for the surgeon not to give big promises to the patients. We can give them smaller promises and can deliver bigger results to the patients. Thanks, sir.
Thank you, Dr. Shashank.